Hey team, it's Coach Candace RN, and today we're here to go over a Next Gen NCLEX case scenario question. Are you ready? Let's go. Today's question involves the cardiac system. Do you know today's NCLEX disorder? Let's just work together today to cover some of this NCLEX content. All right, so I am happy to have with me today a nursing student named Kiana. And Kiana attends a 4-year traditional bachelor's nursing program here in the Midwest, United States. Very prestigious program. And Kiana is going to be working through this Next Gen NCLEX practice set of questions with us. And Kiana, just to get a little bit of background on where you are in your nursing curriculum, what year are you, and what are the main classes that you have gotten done? So have you've done your intro to nursing, your have you gotten through adults one yet? What have you gotten done?
I'm a fourth year now. So I'm a senior in pathophysiology,
Mhm.
pharmacology, pathophysiology, med surg 1, and nursing 205, which was the intro to nursing.
Excellent. All right. So this should give you a good backbone for this question, the amount of nursing knowledge that you already have. But I do anticipate you're at the perfect sweet spot for starting to do next gen NCLEX questions. And I also want to mention that Kiana is involved in an externship this summer. So I think that just reviewing and going through the main disorders can be helpful for you in these externship programs as well. So as this is a student, Kiana is a student I enjoy working with, and she's just going to, we're going to rely on her logic to move through today's couple of questions. All right, and I have here a little clue as to what we'll be talking about with our little gift made by my 12-year-old son, Deuce. Let's get started. All right, I'm feeling I'm feeling a little dramatic. We got Thomas Byron, or I'm sorry, Thomas Bryan. He's a 59-year-old male, and he will be our main focal point for the day. He's our client. Okay, let's get some information about him. We have our two nurses here. One's about to get report from the other one. They're at the nurses station. Our two nurses are getting report, and let's read what's on this report. All right, so we're on case study screen number 1. So it's always a good idea to take a look at the main title. It's going to remain the same as you advance throughout the 6 screens. All right, but that first screen is usually where we're here to recognize cues. All right, recognize cues. So we'll start with the client's name. I know this is some small writing, so I'm going to read along as you look, and then we'll tell you where the important things are on the screen. All right. And again, I've tried to duplicate as much as possible the actual way it looks when you go and take the NCLEX. All right, so we have client name Thomas Bryan. He's a 59-year-old male. His reason for admission is chest pain and shortness of breath. His medical history is a type 2 diabetic, hyperlipidemia, and he smokes 1 pack per day. Allergies, no known allergies. Code status, he's a full code. His medications at home are metformin, 1,000 milligrams BID, atorvastatin, and that is 20 milligrams PO daily, and ASA, which is a shorthand for aspirin, and he's getting that 81 milligrams PO daily. All right, so that would be a little bit of background, maybe a PMH or prior medical history on that client. Now, the nurse's notes tab is usually the first one always made available when you have this set up for the NCLEX Next Gen scenario. And usually the other tabs that are available, you can click on them and you will have the opportunity to actually toggle between the tabs and know what's in your EMR or your electronic medical record. All right, so we'll always start with the nurse's notes every time we get to a new screen. And here we are. Chief complaint, quote, feels like an elephant is sitting on my chest, end quote. It's always good to get the patient's subjective terms so that you can add them with the objective data and get a full picture of what's going on with Mr. Bryan here. The onset of this elephant pressure on his chest was 45 minutes prior to the arrival to the where ED. Usually the information about where you're caring for your client is provided in the little title screen that is usually at the top of every page in your case study. All right, so at 13:30, yes, the NCLEX uses military time. Nurse's note was made. It's generally an assessment note. Maybe it's called a focus note. If this is an LPN, it would be called a progress note. Okay, so alert and oriented times 3, diaphoretic. All right, the NCLEX is very much in terminology test, so you definitely want to know all of your medical terms. Anxious alongside that diaphoretic. Cool, pale skin. All right, chest pain radiates to jaw and left arm. All right, last void was 30 minutes ago, and it was 125 milliliters. And we have S1 and S2 sounds being auscultated without murmur. All right. And then the blood labs were being drawn on Mr. Bryan upon his arrival. All right. Lungs, CTAB. Kiana, do you know what that is? We're using a little jargon here. And generally speaking, on the NCLEX, I don't know if you'll have a whole lot of jargon like this, but have you ever seen this? CTAB? And do you know what it means?
I'm not sure what that means.
Okay, well, it's a shorthand, so it's not necessary that you know what it means, but maybe if you see it in a chart or on a set of handoff notes that a nurse will create, usually with shorthand, it means clear to auscultation bilaterally. Okay, CTAB, clear to auscultation bilaterally. All right, meaning that the lung sounds are clear when we apply the stethoscope to the lung fields, all right, and to the proper places on the back. And then we hear that those sounds are clear on both sides bilaterally. Okay, so lungs are clear to auscultation bilaterally, very important in this assessment. All right, denies recent emotional stress or anxiety. All right, so when the NCLEX is giving you the assessment data, notice they only have this index card size EMR here, so they can't give you everything that would be in a real EMR. It's usually broken down into the information that is most important and probably some extra information that you don't really need because you're usually going to get a question where you have all the information and you have to pick out and discriminate what is most important. So here we are with our question. I'll just slide this over here. Click to highlight the clinical findings that require immediate follow-up. And we're going to select all that apply. But first, before we take a look at it, we might want to take another look at the remaining tabs that we have here. I didn't mean to go back. I want to go forward. Okay, there we go. We want to look at the vital signs. And if we can, we'll look at what other available tabs there are. All right, but generally speaking, this is our main question for the first case study screen. It's a click to highlight question, or also known as a highlight text question, where you will have the opportunity to click on your selections that you like, and they will highlight your answer. All right, and so all the assessment findings are listed here. And you're going to find, or you're going to think about which ones require immediate follow-up. Immediate is the important term there because some require follow-up, but some will be immediately followed up on. Okay, so we've taken a look at the nurse's note. Now, let's look at the vital signs. All right, at 13:30, we are looking at a temperature of 98.9 degrees Fahrenheit. NCLEX usually will also give you the degrees Celsius because we have some of our nursing candidates taking the test from Canada or from other international students. Um, um, take this test regularly. And so usually the NCLEX will provide that in both Celsius and degrees Fahrenheit. I don't have it for you here, but 98.9 degrees Fahrenheit. All right, the pulse is 112, the respiratory rate 22 beats per minute. All right, blood pressure 155 over 88. Okay, pain 8 out of 10, and it's chest pain. And as mentioned before, that Mr. Byron or Mr. Bryan, I don't know why I want to call him Mr. Byron. Mr. Bryan complained of that chest pain being crushing pain. He said he felt like an elephant was sitting on his chest, and he said that the pain radiates to the jaw and the left arm. All right, and then finally on pulse ox, we have 91% on 2 liters nasal cannula. All right, that's what the NC stands for, nasal cannula. All right. So, is there anything else to see? Because we don't have the ability, the technology to just toggle between the screens, we're going to advance until we see that we have the opportunity to provide a correct response. So, Kiana, have you had a chance to think about which clinical findings you would go for here?
Yes, I feel like I would go for the second one,
Okay.
third, and fourth.
All right. So, you like diaphoretic and anxious. Absolutely. You would click on that and it would highlight for you. All right. You like cool, pale skin, and you like chest pain radiates to jaw and left arm. All right. You did not select last void 30 minutes ago at 125 mils. You did not select that the lungs were cleared to auscultation bilaterally, or that temperature, or or the S1, S2 sounds, which you determined to be not an immediate follow-up. All right, that is correct. Actually, you are correct. You are 3 for 3. So if you were taking this question on the NCLEX on this day, you would earn the 3 out of 3 points available. If you had only gotten two, you would have gotten 2 out of 3 points available. And similarly, with 1 point, you would have scored 1 point. So it's kind of a partial credit question. All right, nice job. All right, so now we're taking a look at our nurse here who, if you can't see what she's doing with her hands, she is applying an ECG or an electrocardiogram. She's applying the leads. All right. So that is what she's doing there. And then we have a phlebotomist, or perhaps that's our nurse who's coming to draw the labs. Okay. We're trying to draw some labs there. She might even be placing an IV. Okay. All right, so just trying to get your mind to thinking about what that might look like. All right, so now we have moved on to case study screen number 2. Now, case study screen number 2 is where we analyze the cues that we just recognized in case study 1. So you looked for immediate findings, right? Well, now is where we kind of think about them a little bit and make some nursing clinical judgment, all right? The new NCLEX is all about your clinical judgment. They want to know not that you just memorize some things from pharmacology. They really want to know that you're using judgment to move through these scenarios. Okay, so we're going to just put this over here. All right, so now we are looking at, I'm going to make it so that's even smaller. All right, now you'll notice that most of the information that's on the top of the screen remains the same. All right, so we still have a title screen here reminding us that we're in an ED caring for a 59-year-old patient. But it's always a good idea to look at what's changing when the screen changes. all right, around the question, which is usually going to be indicated on the right-hand side, and then what's changing for the instructions. All right, so the nurse has reviewed the nurse's notes from 1330 and the diagnostic results from 1430. Now, if you'll just remember from the two pictures, which you won't get with the NCLEX, but we just did it there to help you think about moving through this scenario, but we drew blood and we did an EKG. So we'll be able to look at those diagnostic results under the lab results tab and be able to use that information along with the vital signs information and the nurse's notes information to answer this question. All right, so we'll start with so don't forget to look at the nurse's notes. That's a reminder there. And there's also a reminder here with this arrow to look at the vital signs again. Just because those screens are there doesn't mean that people are automatically using them every time. All right. But it is my suggestion to you that you always check it out. All right. Just check out what's going on, see if there's any new information, because sometimes a new tab will pop up or new information will pop up that you now have access to. All right, so always check your tabs. Okay, so we're moving forward here in an interest of checking out the question itself. All right, notice here we have the lab results tab available to us now. And so we can see troponin 1 levels. NCLEX provides reference ranges. All right. So you don't have to memorize those per se, but you need to know what those levels are, because how else are you going to know what is considered to be within normal limits or what's concerning for you? Okay. So for that reason, you need to know reference ranges, but you don't need to memorize them per se because they'll be provided for you here. All right, potassium levels. All right, there's your reference range and your patient's lab results at 1430. All right, your creatinine levels are here. Your WBC or white blood cell levels are here. Your hemoglobin levels, your BNP, and then your ECG results. All right. So you have reference ranges and you have your patient, Mr. Bryan's responses. And here's our question. All right. And the question, if we'll read, can I make this bigger? I wonder. Yeah, we can make this a little bigger. Keep in mind for the NCLEX, this is pretty much what you're looking at, text heavy screens for these case scenarios. So you'll need to pay attention to everything on it. All right. Next to this right facing chevron, you'll see the instructions. For each clinical finding below, click to specify if the finding is consistent with the disease process of myocardial infarction, MI, heart failure, HF, or cardiogenic shock, CS. Each finding may support more than one disease process, and each column must have at least one response option selected. All right. So this is called a matrix multiple response question. It's one of the new next gen types of questions. Test takers really like these kinds of questions because they're more intuitive. All right. You can use these questions to help you through the 6-part scenario as well. So here are your 3 conditions, all right? And here are your clinical manifestations. And they're basically the information that you saw in the nurse's note, the vital signs, and the lab results. And so your job is to click yes or select the selection areas, and you can do more than one per row, all right? Because a lot of conditions have similar symptoms to other conditions, but right now you're analyzing to try to find out which condition you are working with here with this particular patient. All right, so let's go one by one through the clinical presentations, and then you will tell me which of these conditions this symptom might be seen in. Right, so I'm going to zoom back out here so you can see your options, and I'll read each one of them out loud. And then you'll tell me as we look at myocardial infarction, we'll go row by row, heart failure or pulmonary embolism. You'll tell me if that particular clinical manifestation or symptom is associated with either or all. Okay, so you'll have your options. Okay, so the first option is chest pain radiating to jaw or arm. So you're asking yourself, is this something you see in myocardial infarction? And you're telling yourself yes or no. All right, yes or no. Chest pain radiating to jaw or arm or and slash arm.
Yes.
All right, so let's see, let me advance us to where we can actually make that selection. All right, and vital signs haven't changed here, so nothing new to add there. All right, but let's go for making our selections. All right, and Kiana, you believe that myocardial infarction should be selected, and you are correct with that one. All right, now what about heart failure? Is chest pain radiating to the jaw or arm typically seen in heart failure?
I don't think so.
All right, well, that is a correct hunch. We do not typically see chest pain radiating to jaw or arm in heart failure. What about pulmonary embolism? Are you going to see radiating pain with a pulmonary embolism?
No.
All right, so you are correct. We will not see a pulmonary embolism show the chief symptom of chest pain radiating to jaw or arm. So that tends to be uniquely myocardial infarction. All right, with these matrix multiple response questions, usually by the time you're done with it, you'll be able to know which disease process you're working with out of these three because the majority of the choices will be in whatever column you have the most well, the correct answer will be in the column that you have the most choices. All right. So with that said, cool, pale, diaphoretic skin, what is that seen in a myocardial infarction patient?
Um, I think so. And the pulmonary embolism.
Okay, so cool, pale, diaphoretic skin absolutely is seen in a patient experiencing a heart attack. Yes. What is diaphoretic, Kiana?
Mm, I'm not sure.
Profuse sweating. Like sweating where beads of sweat are popping off of the head. Okay. And usually, when you see a patient just suddenly sweating for no reason, your feelers should go off. Your intuition should tell you something is wrong. If they were sitting up fine, temperature regulated, doing fine, and then that you come back and they're suddenly sweating, this should be an encouraging sign for you to do something, okay? Because usually it's never a good sign for a patient to suddenly be cool, pale, and diaphoretic. All right. So, use what about heart failure? Did you say it was associated with heart failure having cool, pale, diaphoretic skin?
No, I think it's just myocardial infarction.
Okay. Well, actually, you might also see it with pulmonary embolism, which is why it's non-specific, this cool, pale, diaphoretic skin, because you could also see it with patients who are going through low blood sugar. All right. So these are just signs of cardiac compromise, but you don't typically see it with heart failure. All right. But cool, pale, diaphoretic is a cardiac sign, a bad one. It usually means that the patient is like tachycardic or they're experiencing some kind of shock that they're going into. All right. So pulmonary embolism, that's another opportunity for you to see cool, pale, diaphoretic skin and start thinking, okay, what is my patient experiencing? All right. Troponin levels. Now, are troponin levels of 2.1 seen typically in, or elevated troponin levels, are those seen in patients with myocardial infarctions?
I think so. And pulmonary embolism.
Okay, all right. So you like an elevated troponin level? Absolutely. For your myocardial infarctions, that is a classic sign. You don't like it for heart failure, which is correct, absolutely, but you do like it for pulmonary embolism. Actually, though, it is not a classic sign of PE. Troponin levels aren't generally raised in PE. So this is one way that you can start thinking, well, if they're cool and diaphoretic, which could be PE, but they don't have elevated troponin levels. Well, maybe not. All right. Now, ECG or electrocardiogram elevation, ST elevation. Now we're speaking about a certain complex in the normal sinus rhythm that is off or wrong. And I'll show you a picture of that later. But do you see ST elevation and when you see 2, 3, and AVF there, they're talking about the leads to the ECG that's connected to the patient. Now, would you see ST elevation in a patient who is experiencing myocardial infarction, Kiana?
Yes.
Absolutely, you would. We got another classic symptom here of myocardial infarction. All right, so the ECG is taken and you see a certain difference in the rhythm. That's going to give you another clue. All right, heart failure. You're going to see it in heart failure or
I
pulmonary
think
embolism?
so.
You think
I
so?
think heart failure, but not pulmonary embolism.
Well, as a matter of fact, you will not see it in either of the other two. It is unique to myocardial infarction. All right. So we're reviewing some symptoms here that are making us think, we've got a lot of positive signs towards myocardial infarction that aren't necessarily true for the other two. Now, here's an interesting one. Heart rate. Will you see an elevated heart rate in myocardial infarction?
I think so.
Yes, you absolutely will. That's going to help explain why they're having that cool, pale diaphoretic skin. Okay, they have that high heart rate. Now, will you see it in any of the other two?
No. I think it could be in pulmonary embolism, but
Okay,
not heart failure at all.
all right. Well, actually, heart failure, you would. You would see tachycardia in a heart failure patient. And we could go through the pathophysiology of heart failure, but that's for another question on another day. And we will definitely go through it because it's a very prevalent disorder, a cardiac condition, and I want you to feel very comfortable knowing the differences between these three conditions. But that said, you actually do see tachycardia in a patient with heart failure, and they take certain medications to bring down that tachycardia because they actually see it often. They see it constantly. All right. Now, pulmonary embolism, yes, as your hunch about that was correct, you will see it in that one as well. All right. So when you're analyzing in screen number 2, you're really thinking through how you can rule out certain other conditions that don't make sense here and rule in others. All right. And we have one last one, elevated BNP. And I can give you a clue that it is true for one of these that the BNP will be elevated. Now, will it be myocardial infarction, Kiana, heart failure, or pulmonary embolism? Which one do you think has the elevated BNP?
What is BNP?
Actually, Kiana, BNP stands for B type natria. It's a long word that's hard to pronounce. And so that's why people usually say BNP. But let me try to say it. B type natriuretic peptide. All right. And that's why we say BNP. All right. It is a very distinct measurement and it usually is associated with a certain cardiac condition. So, which one of the three do you think it might be connected? Well, if you don't know what it is, then you just be guessing at this point, right? So I will go ahead and let you know that it is associated with heart failure. Right? So we do have some symptoms associated with other disorders, right? But the majority of the symptoms are associated with the first column or myocardial infarction. Now, you want to keep that in mind as you move forward to the next screens. All right, so now we're moving forward to case study screen number 3 out of 6. On case screen number 3, you should always be thinking about the the right diagnosis. All right. So case screen number 1 was all about recognizing cues. Case screen number 2 is all about analyzing cues. But case number 3 is about prioritizing a hypothesis. And where am I getting this algorithm from? It's the clinical judgment model. Okay. And the clinical judgment measurement model is what the NCLEX uses to establish or create and grade and generate these questions. Okay, so I'm using that here to help guide you through the 6 steps. Okay, so these are the three questions. They're all drop down questions, and we're going to move through them one at a time. But the instructions on the screen will be typically to complete the following sentence. So that is a close, CLOZE type of question, and you're going to provide some kind of rationale. Okay, so it's a three-part question here, and the assumption is that you've read the nurse's notes from 1330 and the diagnostic results from 1430, which we already did in screen number 2. So there shouldn't be any really new information here for you. You're just basically using the information you already know to answer this question. All right, so complete the following sentence by choosing from the list of options. So the client is most likely experiencing what? Is it heart failure, cardiogenic shock, ST elevation myocardial infarction, or pulmonary edema? Which one you're going to go with today?
I think it's the ST elevation. Am
All
I?
right. All right, so that is, now remember, I always want you to go back and make sure you're looking and toggling through your tabs there to make sure you're not missing anything new. But here we are, ready to make the choice. And Kiana wants to go with ST elevation myocardial infarction, and that is correct. All right, so at this point, by question number 3, you know what condition you're working with. So for the remaining 3 questions in the case study or case scenario, on the NCLEX, you're moving forward as if you're working with a client that has the disease process you picked. All right, now you can't go back on the NCLEX. So if you were to pick cardiogenic shock and then you move forward and you realize, oh, this is a ST elevation myocardial infarction, you cannot change your answer. All right, so you made a great choice and you're moving forward now knowing that you're working with a patient experiencing an ST elevation myocardial infarction or a heart attack. Okay, so now we are on screen number 3. And this is a second, still on screen number 3. We haven't moved screens, but we're on the second part of that, excuse me, 3-part question. And so you still have the option to look at your nurse's notes. You can also look at your vital signs again, or look at your lab results. I always want you to remember to go back and toggle and look at them, make sure there's nothing new. That said, the evidence by part of the question gives you these 3 options. The evidences are first choice, chest pain with ST elevation and elevated troponin. All right, your second choice, pulmonary crackles and elevated BMP. And then your third choice, cool, pale skin. All right, so we analyzed some of these ideas over in the second question, but which one, Kiana, are you going to go with now? Which set of evidences will be aligned with your choice?
The cool pale skin.
All right, so you're going to go with cool pale skin as your evidence of a ST elevation myocardial infarction. All right, that actually is the incorrect choice. Because if you'll remember before, that cool pale skin option in case study screen number 2 was present for both myocardial infarction and pulmonary embolism, which makes it not a unique symptom that's associated uniquely with myocardial infarction. So with that said, chest pain with ST elevation and elevated troponin, those are unique signs of myocardial infarction. All right. So you weren't wrong that cool, pale skin is evidence, but the better choice, and you know, NCLEX loves to give you multiple good choices, but makes you choose the best choice, right? Then the best choice here would have been chest pain with the ST elevation on the EKG and the elevated troponin levels. Okay, because each one of those, while chest pain is not unique to myocardial infarction, chest pain with ST elevation, it is unique, and so is elevated troponin. All right, so now we're going to move back to the next part of that question because it's a 3-part question, making sure we're checking our nurse's notes and our vital signs. That third piece of the question, and all right, so the first piece was Complete the following sentence by choosing from the list of options. It was the patient is most likely experiencing, right? And you said ST elevation, myocardial infarction. And then it said as evidenced by, and we know now that the correct choice would have been chest pain, ST elevation, and elevated troponin levels. And so, and is supposed to finish and round off that list of symptoms. Now, is that last symptom or symptoms decreased urinary output? So you're asking yourself, is that uniquely associated with ST elevation, myocardial infarction, or is it radiating pain and diaphoresis? All right. So which from those two will be your choice, Kiana? Which of the two symptoms are associated with ST elevation, myocardial infarction, or heart attack?
I
Is it
think it's the second one.
okay? Radiating pain and diaphoresis. All right, is the correct response, right? Because radiating pain, especially when it radiates to the jaw or the left arm, are classic symptoms of myocardial infarction. And again, when you combine it with diaphoresis, we're probably looking at a patient experiencing a heart attack. All right, so those are five classic symptoms that probably give you a clue that your patient is experiencing a heart attack. And some require your assessment skills while other clinical manifestations require that you look at your labs or you look at your EKG results. All right, so together, your assessment skills and your diagnostic or your nursing diagnosis skills helps you to make the right choice. So here we are now taking a look at the EMR, right? So I'm helping you to kind of stay engaged in the process that a nurse goes through to work with a patient as they have an emerging crisis or an emerging medical diagnosis or an emerging scenario. All right, so we're back looking at the record, probably awaiting some orders, right, now that we've gotten our labs. All right, so screen four, that's where we are now. Screen four, we should have a new question. All right, we should be checking to see if there's any new information in the EMR. All right, so screen four, we want to take a look at the nurse's notes, nothing new there. And we look at the vital signs, nothing new there. All right, so let's just read, no new lab results either. So with screen four, we're always asked to generate a hypothesis. All right. I'm sorry, a plan. Generate a plan. On screen four, we're always asked to generate a plan, and that is the care plan, essentially, right? So we're really walking through the nursing process here. And here is the part where we do the plan. All right. So, but we are waiting those orders. So these instructions are going to be getting us to think ahead to what we think, because we believe that our patient is experiencing an ST elevation myocardial infarction, or heart attack, but we do not make decisions about what's to happen next. All right. We know our scope of practice is to be able to anticipate what the physician will order and, and protect the patient or anticipate the patient's needs in that meantime. All right, so the question is, what actions would be appropriate for the nurse to take while awaiting additional provider orders? Select all that apply. So this is a SATA question or a select all that apply question. All right, sometimes they'll tell you how many you can select. Other times they will just tell you select all that apply. And the way we look at a select all that apply question is we go through each one of them as if they're a true false question. So you just ask as if they are standalone questions. Ask yourself whether or not that question applies. And then if the answer is yes, select it. If the answer is no, leave it unselected. All right, so we're going to walk through each one, Kiana, one by one. So, which actions would be appropriate for the nurse to take while awaiting additional provider orders? Would prepare for a cardiac catheterization or PCI. Is that a correct choice, or do you think that would be appropriate? Whenever you see appropriate, it's usually something that is just correct or accurate, pretty straightforward.
I don't think that's appropriate.
Okay. All right. So your first choice or your first instinct is to not go for that one. All right. Well, we're going to reveal the answers. I want you to think through them first and then we'll reveal them all together. All right. Let's go through the second one. Administer, because that's how people usually do on these exams anyway. So let's go through your thinking as we go. Administer aspirin, nitroglycerin, and morphine as per the chest pain protocol. All right. Would you do that while awaiting additional provider orders?
I think so, yeah, because I know aspirin is for arrhythmias.
Okay. All right. What about keeping the client in PO? Would you go for that one?
Mm, no, I think I will go with the diet that the provider basically gave us until
Provide.
the provider changes it.
Okay. All right. So you
So
will,
basically, they probably would be on a cardiac diet.
okay. Now, what about place the client on continuous cardiac monitoring, which is also known as telemetry?
Yes. And
Okay.
I wouldn't insert a Foley, and I would make sure to elevate the head of the bed to encourage proper breathing.
Okay. And what about that last one? Encourage oral fluids and light
Um,
snacks.
um, I don't really know about that one.
Now, notice how, and
I
this is
wouldn't
so
like it.
typical of select all that apply questions. Often they will give you two choices that are opposing one another, forcing you to make a decision as to whether or not you're going to go for one action or the other. So, one choice is to keep the client in PO, but the other one is to encourage oral fluids and light snacks. So, it's going to force you to make a decision between those two so you can show the algorithm that you know what to expect next. So, of those two, you already said that you would follow the orders, but now it's really getting you to wonder or whether or not you would actually encourage the patient to take in food or drink. It's a
Yeah.
okay, so you are saying yeah.
Yeah.
Okay. All right, fair. Now, you have never experienced a patient going through a myocardial infarction. You are learning as you go, and you are still in that stage of learning your patient. So it is absolutely fine that you don't have this all figured out just yet. But look, let's reveal our answers and let's see where you were lined up correctly, and let's see where we can help you understand the process. All right. So prepare for cardiac cath. Yes, we'll talk about cardiac cath, what it is in a moment. But once you hear that your patient is going through a myocardial infarction and you are an ED nurse, right? Most new grads are not ED nurses, and that's just the truth because it does take a while to begin to learn these symptoms as they come up. But patients who experience myocardial infarctions have to get cardiac caths. All right, they're basically a diagnostic procedure that helps the diagnostician, usually the physician, understand how much is blocking, all right, the flow of blood through the major vessels that supply the heart. So the cardiac cath is the way to figure that out. That is the diagnostic test. And NCLEX is full of diagnostic tests. That next one, administer aspirin, nitro, and morphine as per the hospital's chest pain protocol. Yes, usually in an emergency room, there are standing orders for a patient who comes in with chest pain to be administered aspirin. Right? Aspirin has a blood, um, an antiplatelet property. So aspirin literally goes in and starts breaking down platelets. And platelets during a heart attack will rise, right? Because there's an injury, and whenever the body experiences an injury, there's an immune response. All right. And so those platelets, but they will get sticky and clog up an area and cause the occlusion to be worse. If so, the aspirin will break up those platelets, those plugs, those things that are causing the occlusions of the arteries in the first place. All right, nitroglycerin is also really important because the nitroglycerin is going to open up the blood vessels and make it so that more red blood cells can get through there and keep that patient having oxygen and not let those cells die that the blood supplies. Okay. And then morphine will help the patient breathe better, all right, and catch they're usually experiencing shortness of breath when they come in with a myocardial infarction. So morphine's job is to decrease the work demand of the heart so that the patient can actually receive more oxygen. Okay, so morphine isn't for pain. Morphine is to help with breathing. Okay. And it should reduce the pain in the patient once they can get more oxygen and stop experiencing the infarction, which is what's like basically necrosis of that blood vessel that supplies the heart. Okay. So keep client NPO. This is a very important part of preparing the patient for catheterization, for cardiac cath. Yes, we do want to keep them NPO. Nothing by mouth, no food, no drink. Now, we might give them that aspirin and we may give them that nitro in a sublingual tab underneath the tongue, but they could also get that nitro as a patch. And depending on the different hospitals and what their protocols are, they're going to take that nitrogen quickly in a way that can be absorbed quickly. Morphine could come IV. All right. So we are definitely going to be giving this patient or expecting for this patient to have IV medications. Okay. Because we're going to be taking in nothing by mouth. All right. And then placing the patient on continuous telemetry. Yes, if we have the authority to do that in our particular institution, we should. All right. Because we already see the EKG was not right. All right. STEMI was present, and we're just giving the team our assessment findings. All right. But yes, it'd be helpful to go ahead and put them on telemetry so that we can see if this ST elevation is real and consistent. All right. And then inserting a Foley, we do not want to do that without a doctor's order. So sometimes NCLEX will trick you into making a choice that is outside of your scope. All right. Some hospitals will allow registered nurses to place a Foley without an order, or if there's standing orders to do so. But in this case, we want to wait on the orders first. All right. But they will need a Foley. So you're not wrong for thinking in that direction. Elevating the head, but don't be fooled or don't let the NCLEX pull you into acting before you've gotten the opportunity to get the order. Elevating the head of bed, and that could also go for administering the medications, just in case anyone's thinking that. Um, if there is no set of standing orders to administer aspirin, nitroglycerin, or IV morphine, do not administer them. Wait for the orders. All right. Elevating the head of the bed. Yes, that you can do within your scope of practice. And you gave a beautifully perfect reason, Kiana, when you said because it's going to help oxygenate the patient better. And then finally, if we're going to keep that patient in PO, we do not want them having oral fluids and light snacks. So you could have looked at that question if you really had no clue around that and said, well, I'm going to pick one or the other because they're asking me to do two opposing things here. And NCLEX will definitely do that from time to time. But the right one here is in PO. Why? Because they're getting ready to have that cardiac cath procedure, and they need to be in PO for that. All right, nice work there. So now we're raising the head of the bed for our patient. Now we're also going to be giving aspirin. Okay, so here our nurse is giving Mr. Bryant aspirin, okay, maybe even a little nitro to go under his tongue. All right, and we're going to observe that patient after we do that. So now we're moving on to case study screen number 5. All right, we're always looking for the new information. So we have, and NCLEX will tell you the nurse has reviewed nurse's notes from, a new time, 15:30, and provider orders from 15:30 as well. All right, so you'll notice the nursing notes or nurse's notes has changed a bit here. You can see that there are new assessment findings. All right. And we're going to think about that as we move forward on the final 2 screens. Case study screen number 5 is always about taking action. All right. So the first screen was recognizing cues. The second screen was analyzing cues. The third screen was picking the priority hypothesis or nursing diagnosis. And the fourth screen was about planning or generating a plan. The fifth screen is usually about what action you're going to take, what nursing action. It's equivalent to the nursing process where we implement. Okay, so with that said, let's read the instructions for the question. Well, I guess before we do that, let's take a look at these new vital signs. And you want to look whenever you have multiple points in time or trend data, you want to look at that and see what's changed, right? Are things head and see what direction the new vital signs are heading in. And then from there, you'll make some decisions moving forward. All right. So at 13:30, here were our vital signs. But at 15:30, 2 hours later, our temperature is 98.0 Fahrenheit. Our pulse is 100 beats per minute. Our respiratory rate, 20 beats per minute. Our blood pressure is now at 130/80 millimeters of mercury. And pain is down to 6 out of 10, and it's chest pain. All right, the pulse ox now reads 94% on 2 liters nasal cannula. So some of that stuff we did before is taking an effect. All right, so now let's look at our new question. Our lab results are still here from before. All right. So just take a note of them. Nothing new there, but we do have new provider orders. All right. So remember, always check the tabs. New things pop up on the tabs. If you ignore the tabs, you might miss some important information that will help you answer the question to the right. All right. So we're on screen 5. We have these new provider orders, and there's a clue if something is new. That clue is usually provided here or just above the instructions here. All right, I'm making some things larger so that you can see them. All right, but the provider's orders are now, I'm going to make this larger so we can read it. Wait, want to come back one, make it a little bit larger. Okay, here are our new assessment findings. All right, the oxygen saturation improved from 91 to 94 on 2 liters nasal cannula. We saw that. The last void is 100 mils. Okay, I think the first one was 125. All right, the ECG was performed and we're awaiting the results from the cardiac team. All right, and then we have placed a 24 gauge venous access device in the right hand. All right, and the lungs are still clear to auscultation bilaterally, but the patient is experiencing some shortness of breath. All right, so the lungs are clear, but the patient has started to experience shortness of breath. Okay, so for each nursing action below, click to specify whether the intervention is high priority, routine, or supportive, or if it needs reevaluation. All right. So is this a high priority action that you need to do that's listed here? Or is this just basically a routine action or something supportive for the patient? Or is this a intervention that needs reevaluation, another look, something for you to question, right? So sometimes there's interventions that are not appropriate. So each row is going to need to have one response. This is when you see the little circular dial, it's only one response required, not multiple responses as we did in that last matrix question where we had multiple responses. All right, so now are you ready, Kiana, to um, answer the question? We're going to go row by row, and we've taken a look at the provider orders. We've read the instructions. Click to specify whether this intervention is a high priority, meaning we need to get right to doing this right away, a routine or supportive action that you can do for your client, or whether this is a particular intervention that is just needs to be reevaluated. Doesn't make sense. All right, let's start with place the venous access device or VAD. All right, so VAD is another term for IV. Okay, so when you see that, just know that we're talking about a peripheral IV. All right, so the orders that came in 2 hours after the patient was admitted would include placing them on oxygen, 2 liters nasal cannula, giving them aspirin, 325 milligrams PO chewed, nitro, zero point 0.4 milligrams sublingual every 5 minutes up to 3 doses, and then hold that nitro if the systolic blood pressure drops below 90 millimeters of mercury. All right. If the patient continues to complain of pain after 3 sublingual doses, then initiate IV nitroglycerin at 5 micrograms per minute and then titrate it every 3 to 5 minutes as needed to a maximum of 200 micrograms per minute. These are the orders that you have been waiting for. All right. Morphine sulfate, 2 to 4 milligrams IV push. All right. And you may repeat that 5 to 15 minutes for unrelieved chest pain. and then telemetry monitoring, the 12 lead ECG or EKG, and then establish a large bore venous access. Large bore meaning that 24 gauge that was in there before, we need to have a larger one than that. Okay. 24 is a small, large numbers, small needle. Okay. Small bore. Okay. And then NPO, we're going to keep that patient NPO. And then, yes, the physician is now saying to go ahead and place the Foley catheter. So these are all of the orders that should be supportive of what you've done so far with the client and what you plan to do. So the question here is, which one should you question? Which orders need to be done right away, and which one are just routine supportive interventions that you can do for your client? All right, because we're on screen 5. So that means that we're taking some kind of nursing action. All right, so placing the venous access device or the peripheral IV, but a large bore one, so a larger one so we can get that um, we can prepare this patient for their cardiac cath. Is that a high priority, a routine, or supportive action, or does this need reevaluation? You need to question this.
Give me a high priority.
High priority. All right. Now, moving on to reassessing pain. All right. What about reassess pain and cardiac rhythm every 15 minutes? Is that going to be a high priority action, a routine action, or does this need reevaluation? Reassessing pain and cardiac rhythm.
Routine.
Okay. Actually, it's high priority, more so than routine,
Ooh.
because what if the ST elevation comes back or persists or changes over into something even more dangerous? All right. And it should be consistent with what would be expected. All right. So there's nursing interventions that you do because of your care plan, and then there's nursing orders or physician's orders that you will respond to. But generally speaking, um, every 15 minutes, reassessing the pain and cardiac rhythm, not a bad idea. Okay, you can have your tech set the patient up, or you can have an automatic blood pressure applied to their arm where it will repeat every 15 minutes. Okay, and then when you go back into the room to check the vital signs monitor there, you should be able to go back in time and see how they've been trending over time. Okay. Um, Now, the ECG every 15 minutes may not make a lot of sense in a lot of scenarios, but we do want to reassess the 12 lead EKG as often as we need to continue to get those printouts and see if we do continue to have ST elevation. All right, now what about provide ice chips and sips of water? Is that a high priority action? Or is that a routine action, or do we need to reevaluate that action?
Reevaluate.
Excellent, excellent, Kiana, because they're NPO, right? So we're not going to just go offering them a lot of sips. In this case, NPO, absolutely, we don't want to. All right, monitor urinary output hourly via the Foley catheter. Is that a high priority item, a routine item, or is that something that needs reevaluation?
Routine.
Yes, absolutely. We should be doing that anyway, right? Patient in the emergency department, and we have something cardiac happening. We want to keep an eye on that output. And the good thing about a Foley is that it helps us to be able to do that very well. All right, and that's something as a registered nurse or an LPN that you can delegate to your patient care tech as well. All right, allow the family one member to remain at the bedside. Is that a high priority item? Is that a routine or supportive item? Or is that something that needs reevaluation?
Reevaluate.
Okay, give me your logic for that.
I just feel like that it would be helpful for someone to be by the bedside, but like not all the time because they could create more stress in the situation than
Yeah,
what it should be. But I mean, I really don't know.
Well, actually, in this case, we're going to consider it to be routine because we have that one there. I battled with this question a little bit when I generated it because, family might be too much. Like a lot of family, multiple family, it can be more stressful for the client. But you have those scenarios where you want the patient to be stress reduced, right? You want them to be able to be calm. We want to bring that tachycardia down. So it may actually be helpful to allow a member of the family who wants to remain at the bedside and keep it down to one, and that could be supportive for the patient and actually help them to feel more calm and help the medications that you're going to be bringing on board to actually work and be more effective. All right, so that's one of those comfort, basic care and comfort type ideas that you want to keep in mind. In the perfect world of NCLEX, that would be considered supportive. All right, so now we're going to keep that patient monitored for their blood pressure. We're going to keep watching their urinary output, and we're going to move on to our final study screen, our case study or case scenario screen. 6 out of 6. Usually, always on the final screen, we're being asked to evaluate. Evaluate is the last step in the nursing process and the nursing process overlaps with the clinical judgment model that's used to develop these questions by the National Council of State Boards of Nursing, or the NCSBN. This is their algorithm. This is their model. And so I'm trying to get that model in your brain. I'm trying to help inculcate that model into your brain. Okay. So with that said, last step is all about evaluation. Anything new here? All right, I will make the nurses' notes a bit larger so you can see them, but there are new nurses' notes provided at 1730. There are going to be some new vital signs, and then there's also new provider orders. Let's take a look at these nurses' notes. At 1730, the last void, and usually with NCLEX, they're giving you any new information they're giving you, they want you to notice the change in the trends. All right, so they're usually not trying to overwhelm you with too much redundancy. They're usually trying to give you additional information that shows where the patient's trending, whether it's up or down, whether they're making improvements, or whether things are getting worse. All right, and just a quick note, it's okay if your patient is worsening at the end of your case study question. It is not a reflection on you as a nurse that they end up doing well. It's not like a video game where you want to make them, you want to heal them at the end of the game. You just want to make sure that you answer all the questions correctly. So if you see that they're trending poorly, then you have to indicate that if the question is asking that. All right, so that said, 1730, we do another assessment. We see that the patient's last void was 55 milliliters. All right, we also noticed that another EKG was performed and we're awaiting the diagnostic results. So we should be able to click on that tab there and see what the latest ECG was. And then finally, the lungs are still clear to auscultation bilaterally. Those are the latest updates to the nurse's notes. All right, let's look at the vital signs. Let's zoom in here so we can see what trends are being updated here. All right, the temperature is at 99 degrees Fahrenheit. All right, you can compare it to the two prior. The pulse is at 115 beats per minute, and you can compare it to the other two. All right, we have a respiratory rate of 20 beats per minute, a blood pressure now of 90/64. The pain number is down to 2/10, and that's located at the site of insertion, okay, of the cardiac cath. And then finally, the pulse ox is at 96% on 2 liters of um, oxygen, okay, by nasal cannula. All right, so those are the updated vital signs. All right, so what other new information do we have here? Lab results. Okay, the laboratory results, I'm going to make this bigger so we can see it here because now we have a second set after the 1430 or 2:30. NCLEX does like to use military time results. We have some 5:30 p.m. results here that came on to add to the mix. All right, so troponin. We've determined on one of the previous questions that troponin is very important to the myocardial infarction disease process. When it's elevated, we know that the patient is at risk for or has experienced a myocardial infarction. All right, it was at 2.1 All right. Our reference range for troponin levels should be less than zero point zero 0.04. All right. So our troponin levels are at 2.0 a few hours later. Potassium. We have 4.2 as our potassium. It's now at 4.3 a couple of hours later. Creatinine levels, all right, 1.2 milligrams per deciliter. It was 1.1 at 2:30. Our white blood cell counts, all right, are at 10,000 per millimeters cubed. All right, the hemoglobin levels, 13.5. The BNP is still the same at 112. All right, and the EKG has changed. It is now at normal sinus rhythm. Okay, so with that information, we are now going to look at our question. And oh, there are no new provider orders, but I again always think it's a good idea for you to um, take another look at all of the tabs, all right, every time you go through a new study screen. For each finding, click to specify if the finding indicates that the client status has improved, worsened, or is unchanged. All right, and this is another one where each row must have one response option selected. So improved, worsened, or unchanged. All right, and so I'm going to zoom in here a little bit so that we can see these little words a little bit more. And know that you can always go back and toggle between those screens because NCLEX likes to just give you the manifestation or give you the one word, and then you have to determine whether or not the data support an improvement, worsening, or is remains unchanged. All right, so let's first look at chest pain. Now, from what we can recall, I can also toggle back if you need me to. Has the patient's chest pain improved, worsened, or unchanged? Remain unchanged. Now, just to help out here, I will go back so that you can see
I
what.
would say, um, I would say, I don't know. I think worsen. I don't know because I know troponin is linked to like that, but it
Well,
leaves me
here's your
saying.
hard data. You can always go back and look at your nurse's notes to see what proof is there. So you should never have to wonder or guess. You can always use the objective data in your EMR to make these choices, especially on that last question, on the six-part question. They want you to go back and look at the trends over time. All right. So I see at 13:30 we have chest pain here. At 15:30, chest pain is not mentioned. And at 17:30, we have not mentioned chest pain again. And remember, these aren't complete assessments on the NCLEX. They're usually just pieces and parts pulled from a typical EMR. So with that said, um, how would you answer the chest pain row? I think you said
I would say improved.
improved. All right. So let's
And then
see.
I would say lungs improved also because they say it was at 91 and it went to a 94.
Then you think your patient is breathing better. All right.
Yes.
So let's see. Our first one, our correct responses improved. Absolutely. The chest pain, the patient does not report chest pain in those last couple of assessments. All right. Lungs. Now, on NCLEX, when they throw that third row in there unchanged, they usually give you language that you can use to support not being changed. And what we saw was clear to auscultation bilaterally, mentioned repeatedly. So the lungs never got worse with this patient. So when we say lungs, we are really talking about the lung assessment. Okay, so lungs clear to auscultation bilaterally and 13:30. 15:30, clear to auscultation bilaterally. 17:30, clear to auscultation bilaterally. So technically speaking, they were unchanged. Now, the patient could have begun to experience crackles, or they could have started to experience shortness of breath that you could hear as like wheezing or some other something you could hear on auscultation. All right. So when we say lungs, we're usually talking about what you heard when you put the stethoscope to the patient's lung fields. All right. Now you mentioned 94 and 91%. You're speaking of their oxygenation. And usually NCLEX will make that a separate vital assessment of finding. Okay. So they'll say pulse oximetry. So even though it does give us some information about what the lungs are doing, it's usually when they actually have lungs, they're talking about assessment findings, and they should usually use the same terminology, the same types of terms to support an unchanged finding. Okay. All right. So let's move on to heart rate. Now I'll go back to vital signs so you can take another look at the trend in heart rate. Now we saw that the pulse was 112, then it was 110, and then it was 115. Now, do you think the heart rate has improved, worsened, or remains unchanged?
I think worsened.
All right. You know, a heart rate that's elevated to this degree and the patient has already received some medications. I'm just dipping us back to where we were.
Will be unchanged.
What? No, you were right. Worsened. I would say 115. Now it went down a little bit to 100 and was started off at 112. It's actually worse than it was at the beginning, right? Because it went from 112 to 100 and then back up to 115. We want that heart rate down, okay? We want it back into a nice range. So you're right there. Your instincts are to go with worsened, and yes, that's correct. Now, what about this ECG? Now we noticed that the ECG went from ST elevation in those three leads to normal sinus rhythm. So has the ECG results improved, worsened, or unchanged, remain unchanged?
Improve.
Sorry, improved. All right, that's right. That's an improvement. Normal sinus rhythm is ideal. It's what we want. And you can witness that the patient stops having the ST elevation in a relatively shorter period of time. That's why we want to keep monitoring it so we can kind of keep an eye on when that depression or ST elevation goes back down into the normal range. All right, so it's not, that's an improvement. All right. Oh, I gave that one away, but blood pressure, right? Let's go back and look at the blood pressure. It went from 155 over 88 to 130 over 80 and then down to 90 over 64. So what would you say about that blood pressure?
Improved.
You would say improved, right? And I think that's typical, Kiana. I think a lot of people would think, hey, it's going down and high blood pressure is the enemy, right? But in this case, and I made it this way with a little bit more complexity in it to
I
get
think
you
it's too low.
too low, right? It's absolutely trending in the wrong direction if it's dipping under 100. All right. One of the physician's orders, one of the provider's orders involved stopping medication if the systolic blood pressure were to drop under a certain number. All right. So we're getting ready to hit that number. We hit that number. All right. So that's something that should be worthy of note. That's something that should get our attention and something that should cause us to think about how this patient is trending, all right, when we're evaluating things. So we do things with our patient, then we come back and evaluate those things to see what the trends are. And I agree with you that that is a trend in the wrong direction if that blood pressure is getting so close to 90. All right, so that is even though on face value, that blood pressure going, it was improving when it went down from 155 over 88 to whatever it was after that. I think it was 130 over 80. That's pretty good, but then it start dropping even more, and that's not quite what we want. And it's expected. We're giving them nitro, and aspirin, and even morphine. All of that should give us the response of having that blood pressure be lowered, have the patient oxygenate a little bit better. All right, and then finally, urinary output. Urinary output is that change in urinary output. Let's go back so we can make sure we see what that assessment was there. All right, last void, 55 milliliters. And that was the last time we looked. Before that, it was 100 milliliters. All right. And that void has been 55 milliliters since a couple of hours ago. All right. So if you're looking at, and it was 125 on admission. So how do you feel about this urinary output? Do you think this is an improvement, or do you think your patient is worsening according to that urinary output, or um, is that urinary output unchanged relatively?
I would say it could be worsening because normally cardiac patients hold a lot of fluid.
Good, good. That's good. That's a good way to think about it. Right. And how many mils per hour of urinary output would be considered acceptable?
I think 200.
Actually, it's 30. 30,
Oh,
30 cc's an hour or 30 mils an hour is considered to be normal urinary output. So if that patient had 55 mils in less than 2 hours, then they're not quite putting out 30 mils per hour. Okay. So with that said, that is a concern that is actually indicating a worsening of the urinary output at least. Now, it doesn't mean that the patient is crashing, that they have a few worsening symptoms. However, this patient, your patient may be going bad. The patient may still need to have a stent placed or whatever is the next course of treatment for a patient who is experiencing an ST elevation myocardial infarction right before your eyes. Okay. Well, Kiana, I appreciate the hard work that you did with that and being vulnerable and sharing your ideas about what you thought the answers to this particular case scenario would be. Now, I just want to go over just a couple of facts so that you can go away feeling like you kind of get what this case scenario is trying to get you to understand. All right. So let's just think about a couple of facts about the myocardial infarction. This here in this um, uh, graphic or this little quick video GIF, you're looking at red blood cells moving through the blood vessels, right, in a clear, kind of unoccluded way, right? But what happens when the patient experiences atherosclerosis, right? It causes like the little plaque buildup that could happen here on the sides of the walls of the patient's blood vessel rupture, all right? And then that could cause a blockage to the blood vessels that supply the heart, okay? And any heart muscle death is called ischemia. And again, ischemia leads to infarction or death of the blood vessel. Okay, so risk factors would be smoking, hypertension, diabetes, high cholesterol, obesity, and even stress. All right, what are the classic symptoms? A crushing oh, I did want to show you this little image here. And I think it's being covered up here, but I want you to see that this is a stent. This is the little stent that's going to be placed to open up the blockages that are happening from fatty deposits, cholesterol, and the basically dietary habits really do lead to the occlusion of vessels. All right, so we see that in this image here, but the stent is usually placed to actually keep open the vessel after the artery is unoccluded. All right, and that's usually with a balloon where we go through and just kind of clean out the debris in that area and then place a stent to keep things open. All right, that's the treatment for a heart attack. Or they cut the vessels before and after the place where all the blockage is, and they replace it with a uh, pig's blood vessel or other donor blood vessels, all right? And they just make it so that they stitch it up again and the patient's able to have a new, unoccluded vessel. Okay, so with that said, if a patient comes in with chest pain that they describe as crushing, if a patient says it feels like an elephant is sitting on my chest, that is what it feels like when there's no oxygen going to the heart. And the actual oxygen, well, not no oxygen, but there's a limit or a blockage of oxygen that's supplying the actual heart. All right. So it feels like a chest pain, a crushing pain on to the patient. And that pain happens to radiate down the left arm. And in women patients who tend to be a little atypical in their presentation, you will feel pain in the jaw, the left side of the jaw. All right. The patient generally will be diaphoretic. All right. That's a sign of cardiac compromise and often anxious. And what is anxiety in an emergency crisis? It usually feels like the patient will say, like, I feel like I'm going to die, or they feel like impending doom. That's what we're talking about when we say anxiety. We don't just mean, no, I'm worried about how I'm going to do on that test next week. It's more like anxiety, like they look nervous, they look like they're afraid for their lives. Okay. And then finally, the atypical signs, I mentioned before, they don't show up the same in men and women. And this is one of those NCLEX questions where you might actually see that they'll tell you whether the patient is male or female, because that's not always the case. They don't always tell you that the gender or sex of your patient. So if that said, if they do give you information about your patient being a woman, you might see typical symptoms look a little bit like shortness of breath, fatigue, even confusion. All right. And that jaw pain versus the arm pain. All right. So know that those symptoms are genderized and slightly different for your male and female clients. All right. I think I did have a second chart here that just showed you what ST elevation looks like on an EKG strip. All right. So we don't have enough time here to go through the entire EKG strip. But I did want you to know that in a normal EKG, normal sinus rhythm, you're going to have here the P wave. That's what we're looking at here, followed by the Q, R, S complex. All right, Q, R, S. And I do encourage you to check out an EKG lecture. There are lots of them on YouTube so that you can, or go through your notes if you've already had this lecture, just to feel more confident about the different important places on the EKG strip. All right, but Q, R, S, right? And then there's the T wave. All right, so between S and T is where you will experience the elevation, all right, that you see here. All right, between S and T is where you can see depression here. All right, so the problem that you're going to be looking for, generally speaking, will in a patient experiencing myocardial infarction will be here, ST elevation. All right, so with that said, the diagnostic tests are usually EKG, ST elevation. Also, though, increased troponin, as we mentioned before, and we diagnose all this with the cardiac cath typically. All right, EKG is used to help us see the ST elevation, and the blood draw helps us see the troponin, but the cardiac cath really gives us a picture of the occlusion, how much of the vessel is blocked, and where we're going to go from there. All right, labs to know, troponin, white blood cell count, because they will be elevated in a patient experiencing a heart attack because it's injury happening to the heart. It's an inflammatory process. All right, the BNP could be elevated. All right, it's a little contradictory to what I mentioned before with that being unique to heart failure. And our patient did have an increased BNP, but again, our increased BNP, we want to kind of keep that more associated with heart failure. All right, the person will have a normal potassium. It's not necessarily hyper or hypokalemic with heart attack. Creatinine could be normal. Hemoglobin will be normal. All right. EKG clues, we mentioned those before. Typically, the ST elevation. In the treatment, remember the MONA protocol, MONA, morphine, oxygen, nitrates, aspirin. All right, that's what you're going to do to treat your patient in the acute stages of a heart attack. And then finally, we're going to send them over to the cath lab where they will also get some treatment over there. All right, because they're going to give you a big, huge insertion of a huge bore needle that will go into the femoral artery, into the leg. All right, that's why we afterwards, after a cardiac cath, we want that patient to lie flat for about 4 to 6 hours because we don't want them disturbing that opening, that insertion site. All right, and any complications that could come from a heart attack will include heart failure, possibly, cardiogenic shock, which is a whole nother lesson that we could take a look at, arrhythmias, and then there's always the chance of a reinfarction. All right, so those are just some of the key tips. I didn't want to give them to you before we went through the lesson because I wanted you to be able to make those correct choices and challenge your brain to do a little bit of active learning, which you did. And thank you so much, Kiana, for your participation in today's lesson about myocardial infarctions. And to those of you taking a look at this video, you are welcome to join my live Zoom sessions, which we're having every weekend here during the summer months. And if you want more information about the course, if you want more information about myself, Coach Candace RN, just subscribe for more. All right. Thank you so much and have a good one.